Welcome everybody to our evening first session of 2022, Not Another New Year's Resolution, Patient Motivation and Goal Setting in Primary Care with Dr. Arlene Cox. We're going to start this session with a land acknowledgement.
My name is Carolyn Nowry, and we would like to recognize that our work takes place across the territories of Treaties 6, 7, and 8, and the homeland of the Métis Nation of Alberta, including the Métis settlements.
Je reconnais respectueusement que je suis située sur la terre du Traité 6, territoire traditionnel des Premières Nations et du peuple Métis.
At some point, for most of us, our families immigrated here and began new lives in this new land. Many Indigenous peoples were displaced from their traditional lands and ways of life. This began a chain of atrocities, the effects of which persist to this day.
I'm Ginetta Salvalaggio. I'm an academic family physician in Edmonton. I'm Misquechi Waskahigan. So what does land acknowledgement mean to me? It's about connecting to all beings, because that's what health is all about. It's not just about me individually as a biologic system. It's about all of us together and all of us who live on the land. If the land is sick, everybody and the land suffers. It's about understanding that disconnection through homelessness and mental illness has an impact on everyone, because we are all connected. It means walking with, not for. It means amplifying voices. It's about insisting that I'm at the table to change some of that.
I'm Kathy Scrimshaw. I'm the medical director of the Collaborative Mentorship Network for Chronic Pain and Addiction. I'm very happy to be moderating this session, our first session of 2022, year 2 of the COVID-19 pandemic. And I am delighted to have Dr. Arlene Cox here to share her knowledge and the stage. Before we get started, we will have to go through some disclosures. I am a part-time employee of the Alberta College of Family Physicians. I have no other disclosures. Working with me tonight are Dr. Leah Phillips, Carrie McNabb, and Agatha Grachowski, and they are paid employees of the Alberta College and don't have any conflicts to disclose. Our financial support for this program is given to the Alberta College of Family Physicians through a Health Canada Substance Use and Addictions Program contribution. It does not receive any in-kind support. And some housekeeping for tonight's session. To capture your attendance, please click on the survey link in the chat log to enter your name and email, and it will come up a couple of times, usually during the evening. We will be using the chat log to collect questions if you want to wait until the end of the session. But Dr. Cox is also very happy to answer questions as they come up in the evening. I'll try to keep an eye out, as you can use the raised hand function. If I miss you, unmute and try to ask your question when it's relevant. And we'll also have a dedicated time for Q&A at the end of the session. And it's really important to us to get an evaluation so we know what worked and what didn't. So please fill that out at the end. And so, as I said, Dr. Arlene Cox is a registered psychologist who's worked in numerous settings in chronic pain in Canmore at the Chronic Pain Center, the program that was developed. Actually, I remember when it was developed because there was nothing like it in our province and probably in the country. And then she moved on to the Calgary Chronic Pain Center, bringing that focus on pain, neuroscience, patients understanding that neuroscience connection of pain. And more recently, she's been looking at health change methodology and has been working with AHS programs. We're delighted to have her speak tonight. And with no further ado, I will let her take over.
Well, thank you for that very generous introduction, Kathy. Much appreciated. So I'll share my slides. Hopefully that's working well for everybody. Excellent. So conflicts of interest, I think I saw that coming up in the chat as well, but I don't have any to report. I don't make any money from these kinds of things. I put at the bottom biases many, because I do think that's something that we need to be wise about as well, that we need to be aware of how our biases impact. And I always love those that encourage me to make sure I talk most with the people that disagree with me. That's probably the best approach. Learning objectives today very much want to kind of highlight when's the best time to start talking biopsychosocial. What are realistic expectations in this kind of work for us as well as for our patients? And SMART goals have been around a while, but how we can maybe perhaps highlight the sabotages we can fall into, how we can maybe plan ahead for them, and then what kind of motivational tools might help us with the most common sabotages in setting goals for clients. So setting the scene, and you'll notice that first little icon, health change inspired. So this is a principle or frame from health change methodology, which I will speak a bit more of. But the idea of who am I? What's my goal today? What do you need to know? So I've been doing this for over 28 years. So when I wrote this slide, I went, oh, wow, yes, it's been a while. Very much in that time, what the best treatment is has changed. What I did in the 90s is not what I did in the 2000s or the 2010s, and what we're doing even now in the 2020s is different. And I want to make sure that I am aware of that changing moving target, that my clients are aware, that we're more of a curious stance, like what's working now, and always coming back to, is it working? What's the outcome? And over, what we know that has consistently been, so whether it's not, we focused on describing pain this way, for example, or treating diabetes this way, the one thing that we know in any treatment relationship is it's the relationship. If you want to look at any research that has the most power behind it, the biggest effect size, it's the alliance you create. So it's always about first looking at building trust with your patient before we build motivation. Motivation comes from that relationship. This is where I find the health change methodology kind of frame a helpful one. So I put down at the bottom the link to Alberta Health Services and training that's available in health change, originally from Australia. The AHS crowd are actually working on trying to get some freedom to make some more changes that better fit some of our needs. But one of the most attractive things about this methodology is this sense that there's a pathway. And some of you, and I'll be talking about it a bit in the next few slides, is that whole stage of change model and the process people go through to make change. This methodology really highlights that. And there's a nice distinction. There's above the line, when the person is not ready for details. This is not SMART goal setting times. This is not, here's a nicotine replacement therapy, go use it. This is, what do you know about smoking and its impact? What do you know about stop smoking? So first we start with that. What do you even know? What do you understand is potentially a problem here? Then we move to, are there expectations for change? Are they motivated for change? Are they ready to make a decision or a commitment to change? So it's above the line, am I ready yet? Below the line, we can get into the details, the specific things that they may need to know. But it helps with, for us, also knowing, what do I need to focus on? If I'm in that first place, it's the trust, it's the relationship. The second level is, okay, what's important to you? What are your priorities? That's how we connect with motivation. So it's a nice frame, and I'll keep kind of moving back and forward on it. I also wanted to bring up one of my favorite tools I use for all kinds of communication. I particularly like this one because its overarching message is, if you want to communicate well, there's two things you need to have an agreement: mutual purpose, why are we communicating, what's our purpose together, and mutual respect. So if we think of that same frame for working with our patients, mutual purpose, the best possible health outcome for them. They want to be healthy and feel better. We want them to be healthy and feel better. We probably have very different views on how we're going to get there, but we want to start with that mutual purpose. Really honor that they're doing things to help themselves feel better, even if it doesn't always look that way. So another frame from health change, and I really like the kind of simplicity of, what's the first step is what, the second step is why. So what do they need to know about the health condition that we're talking about? I work in chronic pain. What do they need to know about chronic pain? Don't assume they don't know anything. I have clients that teach me about soluble and insoluble fibers. They know a ton about nutrition, but they're there to see me because they're still not eating better. So it's often not a knowledge barrier. We do want to check that knowledge. It's an essential step, but we often want to first ask, what do you already know? Because they probably know a lot. The second level then is why. Why do they care? Why do they care about diabetes and how it impacts us? Why do they care about pain neurophysiology? This is where we start to find their motivators. This is the impact stuff. Why do you care about diabetes? Because I'm worried about losing my eyesight, because my uncle lost his foot. These are the things we can grab hold of to help go to the next step, which is, what do you know about treating it? That's the lovely part with the pain neuroscience and the changes in pain treatment nowadays. The range of things they can do that can effectively help their health condition are broad. And that's also part of our duty of care. It's our duty of care to share the what. The next step is always, though, the why. So what can you do to manage your diabetes? Well, you need to check your blood levels, your blood sugars. Why do I need to do that? How might that look? One of the things we found with health change, and when we ask patients, they'll often say, they told me what the what would be, but they really didn't tell me the truth of it. So the person who's told, so listen to a lovely young woman in her teens, had chemotherapy for her cancer. Sure, she understood she was getting chemotherapy. She didn't know she couldn't go to school. She didn't know she would be so immunocompromised she'd be in her room all through high school. She didn't know that why. That was a very different why for her. Realistic expectations. So coming back to us, what do we expect? We hear about patient-centered, patient-focused treatment. The evidence shows us that it's far more likely to lead to consistent behavior change. So we want to be committed to that. We want to honor that, yes, it is our patient's needs. These are the basic principles from health change. And one of them you can see there, client-centered, client choice, client control. Those all sound a bit dodgy. So we do want to unpack, what does that mean? Client control does not mean that my clients get to say, I like hydromorphone. I want to keep using hydromorphone. I'm not changing that. It's about having those conversations and being very upfront about what is control, what they can control, where they start, what they look at is important. Other principles I'm going to explain a bit or unpack a little bit more is the RIC principle, that whole idea of how ready or important it is. We know about trial and error. Let's be honest about trial and error. When clients say, I feel like a guinea pig, it's like, you are, because we don't know. We can unpack the human genome, and I have a really strong sense that there's going to be people who don't respond well to gabapentin, but we do not yet know who that is and if it's you, and it's worth a try. So trial and error is very much the frame we want. Again, curious. We're going to have this conversation. We're going to work on this together. One in particular that is on this base, and it is literally a pyramid that we build at the start and build from there with these principles, is first ask, then offer. At the Chronic Pain Center, this is probably one we committed to, we queued ourselves for, we really wanted to do this, and it sounds easy, and it's not easy to do, because it's so easy when a client gives you something to go, I've got a great idea of what you could do about that. We go running down that line, and then it's like, first ask, then offer is, I have an idea. Would you like to hear more about it? That weight, that invitation, so we feel like a team. Again, relationship builder, motivation builder. Many of you have probably heard about the stages of change. I took this graphic from one of my favorite books in my early training on group treatments for substance abuse. I always liked this little guy. The idea of that with stages of change, people are in different levels of readiness. So again, health change methodology took what we knew to be effective models for understanding behavior change, like stages of change, like motivational interviewing, cognitive behavioral treatment concepts, and merged them. And what we see is with stages of change, and this is something that 28 plus years ago I used in my PhD work, was looking at what are we ready for and how we as healthcare providers can be on the same page. Because over and over, we have tons and tons of paperwork, all this research on these lovely ideas, these lovely treatment strategies, and our clients don't do them. They don't do them consistently. They don't follow through. They don't take their blood pressure medications. They don't monitor. We send headache diaries to tons of clients. Maybe we get 10% filled in. So we have to look at what are they ready for? What do they want to see? And as this model shows you, we have that sense of pre-contemplation, before, contemplate, to think. So I'm not even think of it as a problem. It's not even on my radar. Other people might see it as a problem, but I don't. And then contemplation. And clients really kind of get the suddenly in this place where they're wondering if they need to do something different. Clients will come into our pain center saying, I know I need to change my medications. I don't feel good on these medications. I just don't know what else to do. So they're looking for ideas. They pay attention. Suddenly the world is full of adverts or conversations with people who are working on the same stuff. And again, one of the things we really like at the Chronic Pain Center is that we're able to do the groups where clients can see that other people are in those places or having those questions that can be helpful. Preparation is the stage where we go from, I probably need to do something, to what will I actually do? Do I have the skills? Do I have the finances? Do I have the confidence to do that? So if we could talk about contemplation being a time when we sell the benefits, preparation is a time when we talk about the barriers. Action stage is obviously the Nike stage when they're actually doing it, learning the things. Then maintenance is that stage when we're in a bit more of a rhythm. It's more of a good habit now. Our job is to keep figuring out where we are on that. One of the things in the last 28 plus years we're learning about stages of change is it's a moving target. It's certainly not a linear, it's very fluid. And people can change their stage in a day. Start the day confident, and by the end of the day, it's not happening. So it's essential for us, back to first ask, is where are you at today? We left last time with you having this plan. Where are we at with that today? Is that even what we need to talk about today? And I say over and over to clients, I'm in sales. Today we're talking about relaxation strategies, and I'm going to sell you on why adding a relaxation strategy to your life may be useful. And I'm also going to look at how do we do that in a real world fashion, because it's not like we all have another 15 minutes hanging out in our day. We can do a relaxation strategy. So what is that going to look like for you? It's the second stage, the second into the preparation that we start to look at that. What are the barriers? What are the costs? We call this the decision balance scale, and often use this with clients, that whole idea that, okay, tell me what are the pros and cons of what you're doing now. So you go to bed at any old time you feel like, you get up at any old time you feel like, but you're not sleeping well. So what are the benefits of that life? What are the costs of that life? I really want to encourage them to be honest of what the benefits are. They are not crazy people. They're getting something out of this. So although there used to be the days where people would say, I smoke a cigarette and I feel more calm, and then someone really wants to talk about, well, nicotine's a stimulant and physiologically that doesn't make sense. It's like they feel more calm. That's the benefit. So if that's a really essential part for them, then we need to look at, okay, let's figure out other ways you can feel more calm, you can wind down. So then you have multiple tools, and then we can start letting go of the cigarette for that role. So let's have a look at that. So often it's exploring the benefits of what they're doing now that helps us with that next motivational step. And this is where that RIC principle comes in. So RIC stands for ready, important, confident, and knowledge. And there's a very intentional reason why the K is small, because rarely is knowledge the issue or the problem for clients. It's often about readiness. It's often about importance. Is this your goal now? In this moment in your life, do you have the time, energy, effort to commit to the kind of work this goal will take? So 0 to 10, people actually quite enjoy it. It's a simple measure, 0 to 10. Today, right now, if I asked you 0 to 10, how is important is it for you to stop smoking? If they tell you it's a 6, let's unpack that. What is it about that makes it not as important? What else is more important right now, right? Is this the right place to start? We want to have those conversations because it's their motivator, that impact for them, that is the why, that we kind of, the embers of motivation that we want to gently blow on to help that fire, that passion for the change grow. If it's important, yes, I really want this, then it's unpacking their confident. How confident are you? You could do that tomorrow, or you'll do that this week. And if it's not high, again, what do we need to look at? How do we need to unpack that a bit more? So it's a very nice kind of check. Am I diving below the line because they're actually not ready? It's not important yet, because it's not until we get to checking that importance and confidence that we want to start in the details of it. And the details of it. So the SMART goals, really honoring that what do they need to know? Why do they care? Then we can start to build those goals. So, okay, it's important to you. You're confident that this is the right goal to focus on right now. Let's get specific. What is it going to look like? I mean, the SMART goal concept's been around since the 70s. And it was originally designed to actually incorporate industrial organizational work, where it came from. So looking at goals within a company. So M was often measurable, meaningful. R was often relevant. So employees didn't do well if you set goals that weren't relevant for their job. Like, that's a nice bigger goal, but this is my goal. I count widgets. How is it relevant for me? So we want to think about that for our clients too. Is this relevant right now? Is it our goal or their goal? Does this make sense for the timing? So really helpful to unpack and ask those curious questions. And time limited, daily's better than weekly, and weekly's better than monthly, and monthly's better than yearly. So the shorter time, back to our curious hat. Okay, if it doesn't work in this week, then what do you need to look at for next week? What was it? Was it a weird and wonderful thing that got in the way and this is still a good goal? Or was there something that you learned about it not working out that we now need to look at how to modify the goal? So we do tons of kind of unpacking and retrialing. It is absolutely trial and error. Very rarely do we get this right the first time. One of my absolute favorite quotes is from Dan Miller, a gentleman who got polio at the age of 18, became a motivational speaker, as well as many other accomplishments, and who always said, anything worth doing is worth doing lousy the first time. And I tell every client that, because why would it go smoothly the first time? It's the first time. Sabotages we commonly see, and I'll often use the same phrase, I'm too sore, to help people kind of really get a sense of when we talk about goal sabotages. If you said, I'm going to go to the gym this week, and you didn't go because you were too sore and it was a reason, you really were too sore that day, you were definitely in a pain flare, going to the gym would not have been a good idea. Sometimes it's an excuse. So we say, I'm too sore when someone wants us to do something, and we know that it's not good for us, and it's not really the reason we're saying it. It's just an easy way to get out, but we're honest. We know that. You want to come to dinner? I don't really want to have dinner with you, but I'm going to say I'm too sore. Rationalizations and habits are the tough ones. Rationalizations are when we are scared. We don't know. We talk ourselves out of it. I don't know. Maybe I'm too sore. If I really think about it right now, I am feeling pretty sore and I'm pretty tired. I don't think I should do that. So we talk ourselves out of it. Or they're the old habits. So someone asks and we always say no. So we say no. We don't think about how might I say yes to it this time? What might I do different this time that might help? So again, those are the things when things aren't working out from a goal, so we want to start to pull apart. What got in the way? So when someone says, I hit the snooze alarm, and it's like, okay, let's try the simple answer, which is we have the snooze and the clock further away, so you actually have to get out of bed to do it. If it then doesn't work, then it's like, that's probably not what the problem is. It's something else that's going on that we need to unpack some more. Back to trust and relationship. If we're both curious, then they can share that stuff. Both this stage of change model and often a lot of other model concepts, perhaps like grief, a grief model we use as well. This spiral model is the idea that when we go to pre-contemplation, it's like we're back to maybe I'm not ready for this. It's not that we go down this stage and then back this stage. We're always at a different level. So this time when I stopped going to the gym, I learned some more things about going to the gym. And then next time when I maybe set that goal, I'll be in a different place. You're always in a different depth. You always do absolutely learn something. So it's not a failure. I really want to make sure I'm framing that with clients, that if it doesn't work, then it didn't work. We weren't ready. We didn't have the right plan. We didn't have the right skills. Maybe the timing changed. COVID has certainly impacted a lot of people's out and about goals, out and about swimming and walking and those kinds of things. So We want to look at, so it very much is a spiral. You're always gaining something, some knowledge. So again, a nice frame. Also want to highlight hot and cold states. So one of the things we've seen over and over from stages of change and the SMART kind of goal stuff is the state you're in at the moment when you're setting a goal may be quite comfortable and you're quite optimistic and you can see it happen, but kind of like AA's HALT. When I'm in these certain states, hungry, angry, lonely, tired, I am way more at risk. And I want to actually plan for that. So for our clients, if they're in a lot more pain, they're far less likely to be confident they can do these things. If we're sure we can change our diet and we can follow this new plan, and then we're hungry, or we're scared, or it's a mood issue and we're sad, we're a lot less confident and a lot less likely to follow through on our goal. So knowing that ahead, exploring that when you're in high pain, how will you continue with your daily plan to do these exercises? What's going to look different for you when it's an 8 out of 10 versus a 4 out of 10? Like, let's unpack that. And maybe how are we going to modify that goal so you can be confident? So I really like to cue clients that there are hot and cold states. We want to be curious about it. When clients are in a pain flare and they're doing a taper of their opiate, those are the moments we need a plan, right? If we can plan for that struggle, then they're more likely to be successful. And there's a number of nice strategies that can be more specific about that. So getting a bit more specific about pain. So number one, I would answer is, it's never too early to talk about pain neuroscience. It's never too early to talk about biopsychosocial. I think we constantly do a disservice when we're not in the emergency room talking about some of these things. The reality is I see more and more in the emergency room, we are talking about these things. We're having people calm down. We're looking at those things. A lot of what we use guided, I love the Explain Pain Supercharged, although I must admit some of the physiological dive deep they did, I was almost sweating when I finished those chapters. That's a lot of extra. But I've given you a couple of links there to kind of dig down into the NOI group's Explaining Pain resources. A large part of their research has been not just in what is the pain neuroscience, but how do we teach it to our patients so it changes their pain? I truly believe, and I have evidence in my own experience and from what their research shows, that if we have a different understanding, we're far more likely to get to that place where those protective responses of pain can reduce. And some of the newer exciting work on pain, reprocessing therapies, on ACT work, a lot of it is changing the perception or the interpretation or perspective we have on what pain means. Resources we send our clients to are Tame the Beast. So the same group that created the Explain Pain resources for us also created a separate website called Tame the Beast for clients. It has a lovely 7-minute video that talks about biopsychosocial, how the message about pain is learned, how it can become overprotective. So we react as if it is a big beast when the actual drivers aren't there anymore. It's still real and it's still very much in their way, but the drivers for it are different. We actually have a lot of our nurses, we either direct clients to watch this video at the start, or our nurses will even watch the video with them and kind of unpack it because it is a short, sweet kind of target. Having said that, it's pretty short and sweet. So at the Chronic Pain Center, we created 5 videos, and that's the link you see there. They're designed to be watched in order, but don't have to be. They're no more than 15 minutes each, and they really unpack some kind of details of, the first one's me on general pain neuroscience. The second one is Sam Parmeter, one of our pharmacists, on the lack of relationship so often between tissue damage and pain. Like pain, chronic pain in particular, does not mean there's damage to my body. The third one, Dr. Penny Ford, psychologist at our center, really talks about why pain is so variable. Our clients are constantly saying it's unpredictable, malicious, it feels random, and we really want that message. It's not. Because we can't predict it, doesn't mean it's random. We have no evidence, and it doesn't even make evolutionary sense. We would have a system that's random. It's responding to messages, absolutely, We may not be aware of what those messages are, and we certainly don't have control of a lot of those messages, yet they are very much driving this changing experience. So we kind of really unpack it, specifics they can do. Then a nice last one, and part of why we did it this way is we wanted our staff to be able to say, I'm having this conversation with you, Joe, and I really hear that you're having this question. Watch this specific video that's right where you're at. This is the question you have. That's the video targeted to help. Let's talk about it after. So the last one is one of our physios, Vanessa, who talked about the practicalities of pain neuroscience. When do you get injections? When do you don't? When do you do passive stuff? When don't you? What do you look at? How do you measure it? So if I have clients that are still all on the biology, I need a medication, I need a surgery, I need an intervention, it can be a very helpful video to watch. But what I wanted to share were what we consider the target concepts. And these are I think that the NOI group came up with 10, skinned it down to 9. I'm giving you 6. These are beliefs in a sense that we want our clients to gain. We want them to know this, because when they know this, they are free to kind of approach this with a kind of treatment that works. I've given you the link on the bottom, Pain Revolution. So one of the things that the NOI group did, the Explain Pain group did in Australia, was we need to take this out to the rural areas. So they literally got on their bike, got a van of goodies, and they biked different small towns in Australia. And that's what Pain Revolution developed, was what are the phrases? What are the ways of explaining this? What can I show and demonstrate for you? So you kind of go, hey, if it's about protection, if it's a nerves that fire together, wire together thing, then I should be able to rewire that. And it's like, yes, if it's about overprotection, how do I let my body know it's safe to do this? Let's talk about that. So it's got some nice resources. You can definitely send clients to that location. But we really want you to be able to say, number one thing we're going to tell our clients is pain is real. It's always real. There's no question about that. If you hurt, I trust you hurt. You're the only one that can answer that question. Doesn't matter why you have it, it's still pain. Works the same way. Doesn't always equal tissue damage. Doesn't mean there isn't tissue damage. We want to be curious about that. We want to check it out. It's about protection. It's got good intent. It's useful. It helps us heal and survive. I want a really different frame. It's not the enemy. You can't fight it. I have no evidence that people who fight their pain do well. Don't ignore it. It's not imaginary. You're not creating this. We want these messages over and over. It's contextual. It matters on what's going on in this moment, the meaning of all these messages in this moment for you, why this person has this level of pain. In the old days when sadly I worked in a WCB kind of connected program, and we'd be forever getting this, is it real? It's like, this is not a useful question. But they would ask us if people were consistent. And the answer is, of course, they're not consistent. And that's lovely. I love inconsistencies. I want my clients to love inconsistencies, because in the moment they say it hurts worse here, but not so much here. We're like, okay, so what are the other messages? When you're we all know, we've all heard about the whole blood pressure thing, the white coat syndrome for blood pressure. Exactly the same issue for movement. So you're in this nice bright white room and someone else is moving your arm and it hurts way sooner than if you're home reaching for your coffee cup. I want them to pay attention to that, to look at that to their advantage, right? And the big number one message we want is, it's real. You can retrain this. It is a movable system. Acute pain, we can lower acute pain. Absolutely. We know that in the moment we can do things that lower people's pain. And I don't mean medications. And it's the same for the chronic world. So we want those messages. This is a slide from my presentation for clients. So constantly talking about, you will have pain when it's useful, when it helps protect you, and when there's more messages of danger coming in than messages of safety. So let's unpack what those danger messages might look like and what the safety messages might look like. I've given a little picture up top there. That's from the chronic pain, the Explain Pain Handbook, the Protectometer or Protectometer, depending on where you're from. And we unpack that safety messages are literally anything that you feel that help you feel better, stronger, more confident, more you, more who you are, more who you want to be, used to be. Any of those things are safety messages. And danger messages or anything that's a threat to them. So any sensations in their body they don't get, things in their tissues, but also their lifestyle, their job, their happiness. Looking at this, you can imagine how COVID has impacted so many of our clients because there's so many more threats out there. Everything's been ramped up, so many more messages about danger. This kind of concepts of sims and dims, kind of catchy, kind of fun, dim sim, dim sum, helps it stick for people. But it's also that kind of question we can have. Is this a dim? Is this a sim? Is this a message that is going to help trigger that protective system? And also, what do those messages look like? So again, this is a slide I'll use with clients. It's color coded like that because that's how the Explain Pain group used it, with lovely little Post-its and things. There's no biological distinction in the sense of these are important 7 categories. It's just a very useful way to talk about it and think about it. But you can think even in the sensory experience right now, like I'm in my own home, so I hear, see, smell, taste, touch things. They're not threatening to me. I'm in a safe zone, those kinds of things. When my clients used to have to come into the center, suddenly that sensory experience is a little more challenging. What you do, if I do something that is, as I say, reach for my coffee cup, the dims and sims on that are very different than if someone says, do this movement or this new activity, lift this, right? So we want to look at all of those messages. I want my clients to be thinking about all of those messages to help explore what they can do about their pain. And it very much is constantly being assessed. So back to that, sometimes it seems very unpredictable. It's like, what could be the messages that you weren't aware of in that moment? When you know that you've got a big meeting coming up and you need to get this done, this is all part of the system that can help ramp stuff up. So we want to do the things that help have those safety messages build and that protection level drop for them. And I want them to know that that's the target. What this slide is highlighting, and I've given you one of the articles particularly focus on it. In our work, we very much are starting to look at who does better. And it's always been about those that literally do the work. So in the cancer research, they're doing more exploration of spontaneous remission. People who get better, way better than they're supposed to. You weren't supposed to be, you're supposed to be dead in 4 years and you're not dead. So we're actually starting to pay attention more to who are these people and what are they doing right. And there was some lovely research on the groups, the skills, the pain management tools that people were using. And you literally can see the people that are actually doing the work were the ones that were far more likely to live past expected times. In our own clinic, we see that over and over. The people doing the work are the ones that start to see pain changes. So it's circular. Always back to, how do I help the people who aren't doing the work do the work? These 3 beliefs written here were the ones in the pain research. So when you look at people going through pain treatment and the ones that do better and have less pain, they made these belief changes. They believe that pain doesn't necessarily mean my body is damaged. So it was scary, but I still did try to move my body and do a bit more. They recognized thoughts, emotions, and experiences affected their pain. So started to pay attention to what they were thinking and how they were feeling and took some responsibility to consistently do that. And last, they truly believed and they started to see that they could change their pain responses. If we don't have changes in those beliefs, we don't get buy-in, we don't get the work. So it's back to, if they have the what and understand what pain neuroscience is letting us know, then they're far more likely to do the work, the why, the motivation. And if they're not, we need to keep circling back. I see over and over for clients, they're like, well, I'm not sure that really fits for me. It's like, ding, 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 I need to stay here. Back on that whole, am I on the right page? There's no point teaching them exercises they won't do, giving them a relaxation strategy link they won't do until we can come back to this first step. Over and over, we see these beliefs have to change in order for clients to do the work and progress. So setting the scene. Health is biopsychosocial. There is no time too early to talk about your thoughts, feelings, and experiences affect your health. Too often, let's try the intervention. And then if no good, go see the psychologist. It's like, no, talk to me before the intervention. I can help you do even better with the intervention. Let's work together on this. I love working with Dr. Bo Partikar at the Chronic Pain Center because he's very much connected to that. How can we help this? This person is less anxious before getting their steroid injection. We're far more likely to get a good result from these interventions. Sports is a fabulous example. You ask any athlete how much psychology is involved in sports, they'll tell you 90% it's attitude. What do we hear about hockey? So poor Johnny, he's not true this year. Previous years, poor Johnny Gaudreau, not doing so well. He's gripping his stick too tight. Absolutely. Every athlete knows they got to set themselves up. They have a rhythm and routine to help this situation. We need to be doing the exact same stuff for health. What's your rhythm and routine? What's your approach right now? If we did some work in this moment right now to settle the system, could we do better? What can we do better, right? So as soon as we start saying, it's not simple, let's really see how complex this system is and what are we going to do about it? We can do these things immediately for acute pain, chronic pain, changes to any of these things. We really want to have that full focus on what's the psychology of it, what's the context, what's the social meaning of this for you. So there's a ton of different tools they can be using to help with their health, particularly with their pain. All of these are well documented, well understood to help, but it's about getting that message. Here's the what, which one appeals to you? Why would you do something different? How might you notice that change, right? So it's not for dummies. I got a Word Perfect for Dummies book right here. Health is not for dummies. Do not simplify this. We don't want them to think it's not simple, right? And I think about that too, is the sense that we get in this habit of who does what and what they're supposed to do in the room and what we're supposed to do in the room. And we can all get into these habits. And we do need to be very curious of, so if someone wanted to start with, how do I even start setting goals with clients? It's like, let's start that conversation. It's like, I'm really not sure where to start setting goals with you. Done. I used to love in the grief work. I had a friend who lost her newborn. And we did a grief presentation because she says, nobody knows what to say anything to you. And it's like, that's perfectly fine to say, I don't know what to say to you. That's perfectly fine. It's perfectly fine to say, I'm a little worried about talking about your medications because I'm worried that you'll think I want to stop everything and I just want us to talk about it. It's like, it's perfectly fine to start with that. This is where I'm at. We bought back mutual purpose. Let's talk about it. So our language is so essential. And this is where I think motivational interview has always been a helpful strategy. It's a very manipulative, an intentionally manipulative strategy. So I always want to be very cautious and careful when I'm recommending motivational interviewing. With health change methodology, they used a lot of these concepts. Really, that first ask, then offer is very much built on what motivational interviewing was suggesting. It's about the open-ended, what do you know? Tell me more about. Right? So then we can unpack. When you unpack that, you're also getting their language. It's like this. So suddenly you hear they're giving you, machine kind of examples, or maybe they're going to give you something growing or not growing examples. So I can go, yes, it's like we need to add more nutrients. And they're like, yes. So then we love that, right? As soon as they're like, yes, you got it. When you give me that, then I know I'm on the same page with you and I'm using the same language. Big focus for motivational interviewing. It's recognizing change talk and sustained talk. I need this. It's too difficult to change. Sustained talk. Change talk. I've been wondering. I tried this. We manipulate. We give our attention where we want to give our attention. We choose where we're giving that. That's part of this strategy. Tell me a bit more about tell me about when you did that in the past and how it worked. Let's unpack that some more. One of the bugbears I think most with MI has been that role with resistance. What a phrase. Like, what in heck does roll with resistance mean? And it very much is back to that whole, that's a lovely feedback when you get that resistance that you're not on the same page. So it's just a little cue to you to go, oh, backing up. That's all that tells me. I'm ahead 2 steps. We need to back up a few steps. I've gone past where importance is. I need to go back to that. And I've written down some of the common resistance traps. When I slide into the expert, let me tell you what I know. That's going to help guarantee resistance. simple questions and answers, usually taking sides. So if they're like, if they're arguing this way and you're arguing that way, this is not a good space to be. So those are all good cues for us that this is more likely to build or enhance resistance. We'll put our heels in and fight back versus, maybe this won't work. David Burns is one of the leading cognitive therapists, and that's a huge strategy he uses for depression. He'll tell clients, I have some strategies that absolutely work. I know they'll work. I'm just not sure that it's the right time for you. So what is that? Well, yes, it is. Tell me more. It's like, I don't know. There's a lot of work. You got to put a lot of effort in, right? It's manipulative. It's intentional. It's that whole idea of how do we have them fight for the change, right? And very much the active listening. The more we can do to summarize. So I hear you saying it's this, this, and this. Sometimes again, with that emphasis, it's like, there's no way you could do this. I don't know why we were even talking about it. It's crazy to even think you could do this. This is too much, right? So then we can really get that emphasis. So those are always the MI strategies that I see as the kind of longer lasting, more weaved into these other strategies. Someone else I wanted to make sure I brought up today, because it can be a helpful resource as well. We've brought her out a few times for pain conferences, is Dr. Elvira Lang. So Elvira Lang, and very much, I don't have any shares in her company. It's too bad. I'm sure it's doing well, but created Comfort Talk. And it's that idea that there are many opportunities when in our language, in the rhythm of our voice, in the pace and how we speak, and even how we co-breathe with clients, we can make a real decrease. So when we first brought Elvira in quite a few years ago now, it was shocking how the biology was demonstrated for them. So she said doing interventions, far less adverse events, far less bleeding in different interventions. As I put up here, the one that stuck out for me, a clear case-by-case cost differential. We don't get the extras. We don't have the adverse events the same if we're setting people up. I've had some tests. I've had an endoscopy. The nurse was amazing. Entire time as I'm going through this, she's like, never in your airway, Arlene, never in your airway. It's like, talk about a sim. Okay, it feels like you are, but it's not. It's okay. We can get through this, right? So there's definitely phrases we can use. I hadn't been aware of until I was researching for my presentation today that there is a new app for patients to use. I haven't looked at it. I don't know how good it is, but I would certainly kind of encourage some of my clients to go there. We do a lot of interventions at the pain center. I think we probably could do a better job of setting that up to be a much more quiet experience for some of our clients, because they can be quite anxiety producing. So again, that's another resource. Lastly, but not least, for us, as we change, we had first ask, then offer up all over the center repetitively, and it would still be something we kept bringing back. These are tough things to stick with. Just like with our clients, nerves that fire together, wire together. We can absolutely retrain our responses. It's like, I love their wait 8 seconds for someone to speak, or why am I talking? That might be another way of thinking of wait. Maybe I should listen and ask a nice open-ended question. I put up here something we give our clients to as realistic expectations. That's a bike, because that link I've given you is to a blog by an engineer called Smarter Every Day. And in this blog, a friend has given him a bike where the front handlebars go this way and the front wheel goes that way. So it's the exact opposite of a normal bike. And if you know how to ride a bike, you can't ride this bike. Not at all. And there's a bit of a lovely, fun show of him going to different stages and different universities and showing the bike to people, and they're trying to get on the bike. You cannot ride this bike. You can't. And you can tell that he's a stubborn guy, and he's not very impressed that he can't ride this bike because his brain's a good brain and he can see what he needs to do, but it doesn't work. So it's a lovely example of neuroplasticity. What do you need to do to get those nerves to fire in a different way? And it's very much our frame at the pain center. What do you need to do to retrain these pain responses? So he tested it. He tried to ride this bike for 5 minutes for every day, and he wanted to see how long it would take. And then I generally ask clients, how long is this going to take? And I get a week, 2 weeks, maybe 4. This gentleman did 5 minutes every day for 8 months. That is a stubborn guy. It's a fabulous little video, and I really like to encourage clients to see it because it's like, what's realistic? This is about protection. This is an overprotective system. This is not doing something for a couple of times a week, for a couple of weeks, and seeing a dramatic change. It does not work that way. Now, if he did 5 minutes twice a day, would it have been 4 months or less? We certainly know there's that slow change, and then there's quite a rapid change at the end. What if he did 5 minutes 3 times a day? That's the kind of thing we ask our clients. I no longer, and I might have in the 90s, certainly in the 2000s, said, no, we don't want to be too overwhelming. Just try this once. No, I'm very honest with my clients. If you want to change the system, pick one thing different, do it every day. You're not going to see a change unless you do. We also highlight in a bit of a tweak. I mentioned headache diaries earlier. If knowing that paying attention to an experience help those nerves connect, then I'm also asking my clients to pay attention to what they want more of. So if I'm looking at a pain diary and they have pain ranges from 4 to 9, I don't want to know about a 9. I want to know about a 4. I want you to be vigilantly looking for 4s. I want you to be super curious when 4s happen and what else is happening around it, because that's going to tell us about SIMs, which is where the money is adding more of those SIMs. So I swear we should all get tattoos. Start low with clients. Start low, small change. Go slowly, not too much. I don't want this cautious pain system to get all fired up and unhappy. It's not the end of the world, it does. But we'd like to stay in this range. And then we gotta keep going. So this back to relationship with you. They're not going to see wonderful changes right away, certainly in the chronic pain world. So main pearls from today, I think we're doing okay. Set the scene, build trust, focus on relationship, back up to relationship. If it doesn't seem like always coming back to that mutual purpose, what's the mutual purpose? Their best health outcome. Often it's about stepping back at this stage so we can keep back getting that relationship to move forward again. It's never too early to talk biopsychosocial, and dim sims, the danger safety messages might be a way you like to do it. There are many ways to do it right. I really highly love the what, why. What do they need to know? What do they already know? But the impact is what matters to them. Right? And last time, confidence. Is this the right time? Do they have the time, effort, and energy to give to this right now? If not, what small part of this could we start with? What thin end of the wedge could we potentially do? So, brief view on goal setting and motivation. Sadly, still don't have a bottle of motivation in my office.
Thank you so much, Arlene. Is there any questions? And while you're thinking, you can put up your hand or just unmute. I had a couple of questions. I guess more of a comment. I did hear that comfort talk, I think at a pain conference maybe 2 or 3 years ago. And the use in pediatrics, that evidence is quite astonishing. So just if you are a family doc and work in Emerge or starting IVs and that kind of thing, I tried it after and it was amazing. It was by being honest, describing the pain, you'll feel sort of a burn and a bit of a warm sensation. It's how you describe it and not bundling and being comfortable. So I was very impressed with that. Is it similar for the procedures you're seeing in the chronic pain clinic?
Yes. Yeah.
So
it
exactly
is.
The same. Okay.
Yeah.
And then, oh, go ahead.
No, go ahead.
Yeah, and I guess the question as a family doc, when you're really limited in your time and addressing that biopsychosocial model, how do you do that initial assessment?
I think it's part about how you ask what the issues are, because most clients will give you a broad range when they talk about it. So you already, when you're finding out what the issue is for them, they're going to talk about the other things it's impacting in their life already, or when it's worse and when it's not. So then you can start to bring in some of those connections. So if they might say it's worse in the mornings, like what else is going on for you? Might be able to have some room there, but it really is kind of having that eye of looking for those. It's so rare to have someone who doesn't recognize that when they're doing better, or when they've skipped a meal, or when there's more stress in their life, that it's worse. Most people totally get that.
Yeah, exactly. The other thing I really liked in this presentation is that spiral model, and the fact that things change over and over. I was interested in talking, I can't remember the exact quote, but keeping the change going, not sustain. And I think I've been guilty of that. And what kind of language are you using if your patient is repetitively coming in, sort of saying, I failed, I don't want to, there's the shame in this relationship, if that makes sense.
Yes.
Yeah. So how are you sort of, not sustaining and really motivating again?
Sometimes it is about backing up a little further rather than targeting that specific. It's a little easier if you could give me a specific to highlight on that one, but sustained talk is keeping things going, paying attention to what's not progress, what's not this, what is the same versus any tiny little bit different. So this time you did set the alarm, which is different, right? Maybe that's part of it. So is there anything at all that you can pay attention to that shows they're attempting some change, or there has been some progress? That negative filter is very common. And because people aren't better, they don't want, it can be that I'll often get a continuum. They'll either come in and underplay what's still a problem, or really overplay what's still a problem. And both are important to kind of get the balanced view, right? I don't know if that helped answer your question.
It certainly did. And I keep going back to chronic disease management and complex comorbidities. And some of the issues I think we face in practice is we get measured on how many of our diabetics are on target, how many people have the right blood pressure. And so that you have these goals that are yours and they're not your patients, and working together. And that's a system problem, and I don't know really how to work around that, but I think it's really, really key. And Laura Nixon just said, quite decontextualized measures of performance.
Yes.
It's a surrogate marker. And I often use the example of working with a diabetic patient who, he's like, I'm not taking my meds because I live in a car. Like, that his goal is housing. It's not what my primary care network wants, that hemoglobin A1C at 7. And so it's really, I think that's what you're saying is important. Then
in my part of why I emphasized and brought in stages of change as a focus at the chronic pain, at the Canmore Pain Clinic, is because so many of our clients were WCB, and so the goal is return to work, and you're meeting these people going, that is never going to happen. And there's a real, like, you kind of like to do this work, but you also need to be working with these real human beings, and this is really what's going on for them. And it's really emphasizing for us is, it's not an unreasonable target to get someone's A1C levels consistent. That's a reasonable target. I understand why it's set. And we won't ever get there unless we get here and here and here, and we're here. So if I focus on this, I am getting closer to that target. So it's about kind of changing sometimes the frame for us. Same with opiate tapers. It's like, this one didn't work, but we are getting closer. If the goal is their health, back to the start of this presentation, the goal is actually getting a relationship with them so you guys can even have a conversation of how to start. That's the goal. That's how we get there. And we have to be okay. And then this is me like, and then the other presentation you need to have is make sure someone comes in and talks self-compassion for us, because we need to have compassion, that we need to be satisfied that we're creating that relationship. And it's far more likely to happen in this place than it would be if you went, odds are better.
Exactly. Now, I know I'm conscious of the time. It is exactly 8:30. I want to thank you for an excellent and inspiring presentation. I wish I had heard it back when I was doing a lot more clinical work. And I just want to mention our next collaboration forum is going to discuss pelvic pain. And we have Dr. Magda Robert talking about pelvic pain. It's not all endometriosis. And so please join us for that. And it's open to all interdisciplinary team members. And this is a very interesting topic. And our next slide is, if you're not a member of the CMN, please consider joining. It's free. Really appreciate everyone's time, and enjoy the rest of your evening, and all the best for the weekend coming up. Take care, and thank you very much for joining.